Thank you very much, and thank you for the opportunity to speak today. I'd just like to say that, before I begin, that this cannot be possible without the team that I had behind me. So special thanks goes to the high acuity team consultants and the anaesthetic registrars, the ICU outreach nurses, and I should also include the medical registrars with that. With the critical care clinical network, the leader of that was Monica Holdsworth. So she was the program manager of the critical care network, and without her help and support and guidance, this could not be possible. And also I'd like to thank the Peter MacCallum Resuscitation Working Group, which from this project we were able to establish, and without their help and support, some of these outcomes wouldn't have been possible. But generally as well for the staff within Peter MacCallum and also our precinct partners. Where do I press to change that? There. Oops, wrong way. So just to give you some background in regards to Peter MacCallum, we were a 7-bed intensive care unit. We had a very limited liaison service. It was Monday to Friday, virtually the hours from 8 to 10, and on weekends only till 8 to 4:30. In June of 21st, in 2016, we relocated to our new premises in the Parkville precinct. So this is for people that are not sure. We're across from Royal Melbourne Hospital and the Women's in the Parkville precinct. This brought about a new model of care and roles for our Met service. Saw the establishment of a high acuity team, and like I just spoke about, we had a new team of consultants, registrars and medical registrars, and the ICU outreach nurse team. Obviously, with not having an intensive care now as part of the new premises, our ICU beds went over to the Royal Melbourne. We also needed to provide an outreach service to the wards, which is not just the Met service, but other things like a trachea round, a TPN round, and also giving support and guidance to the nurses on the ward. This then became a 24/7 service, so we had our liaison outreach nurses working 24/7 with their anaesthetic registrars. Part of this service as well was that we were able to have the high acuity consultants provide structured ward rounds, and we had 2 ward rounds a day in the mornings and in the evenings, looking at our Met patients or patients of concern or referrals that we had. We also average about 160 Mets per month. This is a look at the new Peter Mac and also the foyer of the new building. So it's that building near the roundabout. It's quite impressive. Have a look around it one day, go for a tour. So the critical care project, which was the rapid response team, on the 11th of May in 2016, we were asked to attend a forum and to send an expression of interest. So at this point, we needed to identify something within our organisation that was an issue. So for any of our liaison nurses that are present here today, one of our biggest issues was the fact that we knew there was very low compliance rates of goals of care. Because we were transitioning and we were going to be moving in June, we needed something that would translate from the old Peter Mac site at East Melbourne to the new precinct. So we didn't want to start a project which, when the service changed, that we couldn't look at to see if there's been any changes or sustainable outcomes. So the project was a 9-month project. We were lucky to be successful to be part of that project, and that commenced from July 2016 to April 2017. It was a very good group to be a part of, so I would advise anyone, if you get any of the emails in regards to being part of a critical care network with the Safer Care Victoria, that you get involved. We had a cross-section of organisations, so it was a combination of public and private hospitals, but also different partners from metropolitan tertiary centres to regional centres. So it was good to see that the first forum that we had, that many of the things that relate to the metropolitan also are issues for our regional partners as well, such as goals of care. A majority of us had very low compliance rates with our completion of goals of care forms. It also involved 2 webinars, and so that was really good that we actually got to talk to our colleagues and sort of give advice, see where they're at, give any suggestions, and so that was a great way to network and keep engaged with each other. We also attended 4 workshops for this project time, and a lot of that was to help us with that project management, given us the techniques and skills and tools, but also we had to present back so how our project was going. So our pre-data showed that our goals of care, so we're very lucky that the liaison nurses will always collect that data, so I'm sure like everyone within this room, you've always collected data on the number of MET calls, the criteria for the MET calls, goals of care, resuscitation forms that maybe have completed prior or post a MET call, and we only had 25% of our goals of care forms were documented at the time of a MET call. Looking at this and looking at the research out there and looking at the Australian context, we sort of found that that's not unusual. There can be anywhere from sort of like 18 to 32% of MET resuscitation forms completed at the time of a MET call. We also identified that there's been to be a varied combination between home teams and compliance rates, and also the nursing involvement from the wards as well. We also identified that we had probably some issues around our data collection. It was an Excel sheet. It often was corrupted with different problems as well, and so we needed to look at our data collection solutions. The goals of care completion, we often had conversations with the team and whose responsibility it was to complete it. A lot of our junior medical staff didn't feel that it was their responsibility, but on the actual form it says they are able to complete them, but they need to make sure that these conversations occur with the registrars or consultants, but they are more than welcome to fill them in. So that sort of helped with their guidance in regards to that. One of the big issues we also identified by doing this project was the storage of the goals of care forms. So anyone within my team would be able to tell you that we would go, and one of the first things you want to know is what is the resus status, what's the goals of care, is there any limitations? And trying to find that form was often difficult. They are in different wards, they were in different places, and sometimes even within the wards they were in 2 different places. So some were at the patient bedside folder and some were actually in the medical histories. So that made it very confusing when we're trying to locate a form. The missing form. Our data showed that as we were collecting the data, we would tick that there was a resus form and what their goals of care were, but maybe a couple of days later there'd be another MET call and the form had disappeared. There was now no form. And we find because they're paper, you can actually see that a lot of the times things start ripping out of the forms. So that was an issue and a concern for us. Obviously around the communication, we also know that there was incidences that identified that the home team might have known the goals of care and discussed that with the family, but they hadn't documented that or communicated that. And we had one such incident where the patient was about to be prepared to be resuscitated and intubated when the registrar came in and confirmed that the patient was not for resuscitation. And obviously leadership. So that means also from the governance of the organisation, because this had been an issue for a while and had been presented at committees. So we needed some buy-in from the governance of the organisation, and also from our team of consultants. So with this new model, we had great leadership. So one of the initiatives that we brought about was that we had a hat round checklist, and this was brought in by one of the consultants, Sophie Parker. And as you can see on the form, it actually states, and it's in red and highlighted, that the goals of care form has completed. This is a great way to communicate to the home teams that we've been around and seen the patient, and we've identified this as an issue. It also allows all our consultants as well to have conversations with the home team. So many of them will have conversations with them at that point in time if they're there on the ward. Or sometimes they've actually called the team to actually clarify the goals of care, especially in a deteriorating patient. Another thing that we did, and we're very lucky to have Paul Whitcomb today, one of our ICU outreach nurses. He's very IT savvy, but I tell you to either get someone that's IT savvy or your IT department. So we had a database in which that we can flag whether the forms have been completed. So one of our initiatives was to go back 24 hours post a Met call and to see whether a resus form had been completed. So I don't know if you can see it, but on one column it's got the resus order, so some of it would be whether it had been filled in, whether it was done prior or post a Met call, or whether it had been completed in the last 24 hours. Some of the problems that our hospital will have is that you'll get a patient that's come in and have a Met call on arrival, so no form had been completed, someone from ED or who'd come out of the ICU as well. So that just flagged to our team to see that that form had been completed in the last 24 hours. One of the interesting things is that there is some literature and not much about going back to look at patients 24 hours post. One article from Cameron Knott and his team identified that sometimes there can be 50% increase in completion of goals of care forms post-Met calls, and that's the only research I could find. But most of these patients have probably ended up in the intensive care, and we know that then often that conversation occurs within the intensive care, having the conversations with family in a critical situation, which is probably not ideal. One of the things I was talking about was that the folders were in a different, the goals of care were in different folders. I initially thought that the goals of care form should have been in with the patient history, but engaging the hospital, the nurses, the nuns and the nurse chief officer, they decided from the wards, which is good, to engage the staff, that the resuscitation form would be best in the bedside folder. This way they know if they're doing their observations and their tracker trigger, if the patient is in Met criteria, they'll actually know the status. So sometimes that prevented that Met call for patients that were not for resuscitation because the form was in the other folder with the doctor somewhere and not being able to be located. I also was worried a little bit about confidentiality, but obviously the goals of care, we should be discussing that with the patient. The patients and their decision maker should also know what the resus status is. As you can see, I don't know if you can see very well from the photos, there's also a plastic sleeve. So when we talked about that missing goals of care, this also made it easier that there was a plastic sleeve that the form went in, prevented the form getting ripped out. We knew if there wasn't anything in that plastic sleeve, then the form hasn't been completed. Another thing that we did was, as the ICU outreach nurses, is that we'll often, if we haven't found a form from that Met call, we'd put one in. Sticky notes are our friend. So we would often write a note to the team, dear home team, you know, this patient's had a Met call, can you please complete the form and put it in the folder. The other thing that came about from this was obviously we all had different goals of care. So like we said, our intensive beds are now across at the Royal Melbourne, so our patients will go from Peter Mac by the bridge across the road into Royal Melbourne, and we all had different goals of care forms. So that actually meant that each time the patients came back, if they'd gone to intensive care, had a change in their treatment plan, that needed to be changed when they came back to Peter MacCallum, and would have to redo a chart, a form, and sometimes that wasn't done when they would come back. So we're currently working, part of that resuscitation working group was to meet with our partners across the precinct, and that involved a whole array of like high acuity consultants, palliative care, intensivists, quality, to look at formulating a precinct-wide form. I think now that it's probably just at the point of being approved and just needs to be signed off from the executives across the organisation, taking into effect the new advanced care plan directives that came into effect in March of this year. What was the outcome of our project? So as you can see, the data at the start showed that we only had about 25% of completed forms at the start, and at the end of this project we were up to about 53%, so like nearly half doubled from that start. Our post-Met calls used to only be about 4% of the forms were completed, and that was up to 10%, and I think that was sort of the buy-in with our senior medical staff and the communication with the home teams. And going back and checking that goals of cares and having communication with the home team and the nurses on the wards, that we found that nearly 18% of those forms were completed that never had a goals of care at the time of Met. So that sort of brought our total up to about 81%, although we still had nearly 20% that weren't completed post a Met call. So that was the end of the project. So as we've just discussed, there was about 25% had increased. I will say to the team, and I probably should have said this, I've actually left Peter Mac a couple of months ago to be the nurse unit manager of Werribee Mercy, but the team have continued on with these initiatives that we've brought in, and the latest data shows that they're nearly up to 40% have an increase in the time of Met call. So that data now is looking at completed goals of care forms around the 65 to 70%. At the end of the Met call, there's probably about 5% they're done, but that's probably related to the fact that it's lower now for the fact that we've got that pre-Met call form in place than post. And with the 24-hour post follow-up, we find now that we've got about 89% of the patients that have Met calls have now got a completed form. Part of this project, it was really interesting to go back and look at the patients that then came and had repeat Met calls. So I'm sure everyone in this room knows that patients don't often have one Met call. They might have numerous Met calls over a time period. And some of those patients, I think in the first week we did it, there were 6 patients that had repeat Met calls, and their forms either had limited or not for resuscitation treatment plans. So you can imagine if there's continued not to be a form that was completed, the impact on the team and trying to make decisions and trying to communicate to the teams. So what worked well? Well, I'll say it was the ICU outreach nurses' support involvement to going around and being able to go back and recheck that the forms are being done in 24 hours, making sure that the forms were put in place with the post-it notes. The HAT consultant buy-ins and quality initiatives, obviously going around and having them discuss the goals of care treatment plans with the home teams. Our data resources to improve compliance rates, so there was a reminder for us, and it was very visual and easy to use. We had a better sort of collegial approach, I found, with the home team. So once they got to know the HAT team and the nurses, that we started to establish a really good rapport, and that we're all looking for the best quality outcomes for patients. And also, like we just talked about, getting the buy-in from the ward staff. So they've been auditing, and you'll find that the surgical ward, who had a really poor compliance rates of goals of care around the 20%, now have about 81% completed for all their patients admitted to their surgical ward. Reporting this to the hospital executive by the way of the acute care committee, so they've been able to support some of the initiatives that have occurred with the resus working group and to feed back to the home teams in regards to their results. Like I said, the research working group that also met with the precinct partners to help collaborate together to have a precinct approach to goals of care. Some of the things that didn't work well, in the initial stages, our data collection was very varied. It was individual dependent, but as we all sort of got training and education, that improved. Sometimes what affects us data and having those conversations about goals of care, if we've got concurrent Met calls, so you can't sort of start having a goals of care conversation when you have to run off to another Met call. Some of the things that we still found was that there was individuals within a team, a lack of support from the home teams to have those forms completed, and also some of that accountability. So who's responsible when we know that there's individuals or teams that have low compliance rates? How do we make them accountable for that? And some of the things that the acute care committee is looking at is that ensuring that there's some emails to the departments of the heads are aware and that they're accountable for their compliance rates. And also, everything's as good as things are until there are changes in the team, changes in the medical team. We've got to start again with a new set of medical team, and same obviously within, the ICU outreach nurses team and consulting teams and anaesthetic registrars as well. Just there's some references that talk about, and I just want to say thank you to the ICU outreach team for all their support.